All right, let's talk about heparin-induced thrombocytopenia. The risks are patients who've been on heparin for greater than 4 days. Remember that patient we talked about? They were in the cardiac wards and they're on a heparin drip for atrial fibrillation. So they've been on heparin for greater than 4 days and have been using heparin instead of low molecular weight heparin. Remember, low molecular weight heparin has a lower probability of having thrombocytopenia or heparin-induced thrombocytopenia. Still can have it, but less probability. You have a 50% drop in platelets count from baseline is suggestive of the diagnosis. Now, the true diagnosis is, and these patients can also have a risk of thrombosis. So they have lower platelets, but increased with thrombosis, 75% on the venous side and about 25% on the arterial side. Diagnosis is ELISA for the PF4 heparin antibodies, which is the serotonin release assay, is the gold standard. Now, this is a technically challenging study and requires special equipment and special handling of the platelets and the radioisotopes. So it has limited accessibility and has longer turnaround times. The donor platelets are in the testing, and we're just telling you why I'm telling you this is because to show you that it takes time and why it takes time for you to get the answer back, why you don't hit the button and you don't get the answer back from the lab right away, because unless you're at a super facility, this is going to be taken to a specific lab that handles these. So the donor platelets are intubated with a C14 serotonin, which is taken up and stored in the platelets and the dense granules, and then is washed to remove. The serotonin, it generally takes about 2 to 4 days for the actual test to be done. So then you have the turnaround time. So this can be quite a few days, a week, or some places up to a couple weeks to get this back. But you can't leave your patient in this position to get the test back. So this is why, as we discussed, we use the score, the 4T scoring system, to see what your probability is. Then you can have a discussion with the patient if you want to initiate the therapy. And so what's the treatment for heparin-induced thrombocytopenia? Liparidin, agatroban, or bivalirudin are direct thrombin inhibitors. Has an alternative coagulation until the platelet count. So you're going to give these medications, okay, they're going to be a drip, and you're going to give them until you get the platelet count greater than 100,000. So if you have to be on Coumadin, then start the Coumadin, and no heparin for the next 6 months. You can say maybe no heparin for a longer period of time on that. So can DOACs be used? Now, we talked about before, this would just be warfarin in the past. Is data from 12 publications and across 36 patients suggests the use of DOACs in acute phase of HIT may be safe and efficient treatment with favorable ease of monitoring and management. Remember, warfarin is a good drug. The problem is the monitoring and the changes that can occur from patient's diet, and you can have highs where you have risk of bleeding or lows where you're taking a medication that can cause you harm but not really getting the benefit from you. So if you do DOACs, you don't have to require platelet recovery, so you just start them right away, and once you get the agatroban and bivalirudin started, then you start the DOACs. Transition the patient is relatively clinically stable. So you start those, and if the patient is stable, then you can get them off these treatments. There's no overlap. Start DOAC within 2 hours of stopping the agatroban or bivalirudin transfusion. So this could be a change in what we see in management versus warfarin. So basically, it would get these patients out of the hospital facilities faster, which is good for everybody, gets the patient back home and safer. Thrombocytopenia in pregnancy. So what can cause this? Gestational. In the second and third trimester, the women can have a mild platelet count less than 70,000. No treatment is required unless the platelet gets less than 50,000. ITP, we talked about this, you treat with IVIG. You have an increased risk of fetal intracranial hemorrhage. Preeclampsia, we'll start worrying about this in the third trimester. HIT, hemolysis, elevated liver enzymes, low platelet syndrome. The HELP syndrome, which is again hemolysis, elevated liver enzymes, and low platelets. This can happen. The treatment in 34 to 36 weeks would be immediate delivery. Also, TTP can occur in pregnancy, and the treatment is plasmapheresis. HOS, supportive care, no role for plasmapheresis. All right, here we have another clinical scenario. Patient gets a cardiac cath. Platelets were first in normal, then became abnormal. So patient comes in, gets a cardiac cath. The platelets were normal prior to the procedure, and then post-procedure, the platelets are abnormal. What could this be? Thrombocytopenia. Heparin, penicillin. What can cause thrombocytopenia? Heparin, penicillin. How about this? This would be, in this patient's case, is a G2B3A inhibitor, apixaban, is this very specific one. And you can actually see this, and I actually had this case. This case was a case that I had as a resident, and I actually had a really great cardiologist that said, hey, this is not HIT. This patient just came in, okay, so they can't have HIT. They're not taking heparin at home. They've not been in the hospital in many, many years. So this is a patient who came in and then had the sudden change, and this is where apixaban was the answer that caused them, because they received this prior to the cardiac cath. So they had their platelets drawn, received the apixaban. Then after they had their cardiac cath, then the labs were redrawn. Infliximab, rituximab, H2 blockers. So these are all things that can cause thrombocytopenia, famotidine, ranitidine. And we always kind of think, oh, H2 blockers are safe. We need to stop the PPIs because they can cause everything from dementia to spontaneous combustion. The reality is, those were kind of studies that really didn't play out, when in the real world is the PPIs are actually safe. H2 blockers, they can cause thrombocytopenia. What else can they also cause that is very bad for our hospitalized ICU patients? Delirium. H2 blockers can have increased risk for delirium. So we can continue our discussion. Medications that cause thrombocytopenia, anti-epileptics with valproic acid and phenytonin can also. Antibiotics, which is the linazol can cause myelosuppression. Vancomycin can, and B-lactams can too. Of course, if patients have HIV or hepatitis C, H. pylori, CMV, and lupus, SLE can have thrombocytopenia. Rheumatoid arthritis and liver disease can also present with thrombocytopenia. All right, let's talk about thrombocytopenia. So if you get the labs back, what are something you can do? And you can do is ask that the phlebotomist draws out of a blue tube. And you say, what? Why? So we can have pseudothrombocytopenia. So in the presence, platelets can clump in tubes that have EDTA, which is basically is used preserver that is used in certain colored tubes, and this can cause the platelet count to accumulate, and this can cause us to have problems. Is the blue tube, which has sodium citrate, the blue top, and this would less likely to cause platelet clumping. So you're checking for pseudothrombocytopenia with this. So what do we do if we have thrombocytopenia? Get a platelet smear, get iron studies, get B12, get thyroid testing, check for LFTs, get a lupus panel. These are basic workups we can do for thrombocytopenia. This is an exclusion to say that we're worried this patient has TTP. All right, now let's talk about this. This is a 32-year-old female with livedo reticularis. Now remember, that's that blue net-like, so there's signs of poor perfusion. She's had 2 miscarriages, anemia, and thrombocytopenia. So 2 miscarriages, anemia, and thrombocytopenia. Okay, so what are we looking at right now? Antiphospholipid syndrome, which is an autoimmune disorder in the body which produces antibodies that recognize certain clotting proteins. So these antibodies cause the destruction of the proteins. The antibodies have a special property that causes them to activate the clotting proteins. So they have destruction and you have increased clotting. So you have acceleration of the clotting process. This is an autoimmune disorder that causes accelerating of the clotting process. One should be concerned for antiphospholipid syndrome is when you have clotting while on anticoagulant. So the patient's on anticoagulation and they're still clotting. Clotting in unusual sites. History of autoimmune disorder. High frequency of false positives in testing. So if there's inflammation, so if the patient is in an acute phase, we probably don't want to test at that time. So inflammation and patients being on anticoagulation give us a high frequency of false positives. Do not test in the setting of a provoked clot. The patient is clot, they're having a provoked clot. We do not want to test at this time. So remember, we're producing autoantibodies that are attacking and causing acceleration of the clotting process. Continue discussion on our antiphospholipid syndrome. One or more of the antiphospholipid antibodies is the lupus anticoagulant. Anticardiolipin antibodies, IgG or IgM, in medium or high titer. Antiglycoprotein 1 antibodies, IgG or IgM, at any antititer, plus any of the following. One or more. So we need one or more of those, plus any of the following. Vascular thrombus, we have a deep venous thrombus, thrombosis, or pulmonary embolism, and or arterial clots. So you have venous and arterial clotting with stroke, myocardial infarction. Pregnancy, in pregnancy with morbidity presenting as miscarriage. Remember, in our example, our young lady had multiple miscarriages of a normal fetus less than 10 weeks gestation. Birth of one or more premature babies at 34 weeks gestation because of eclampsia, preeclampsia, or placenta insufficiency. Multiple miscarriages greater than 3 in less than 10 weeks gestation. Continued discussion on antiphospholipid syndrome. Because of other conditions can be transiently associated with antiphospholipid syndrome, the antibodies must be present on 2 separate occasions and at least 12 weeks apart for diagnosis of antiphospholipid syndrome. So it's a little bit more difficult than the others. Well, not included in the criteria for diagnosis, what else can you find? Liver reticularis, which we discussed. Sterile cardiac vegetations, Lead-Mid-Sachs syndrome. This is vegetations that can be both on the ventricle and atrial sides of the valves. Most effective valves are the left-sided chamber, which is the mitral followed by the aortic. What else that is not included in criteria but can be found in antiphospholipid syndrome is thrombocytopenia and prolongation of the partial thromboplastin time, the PTT, caused by lupus anticoagulant. Elevated PTT and a normal PT can be found on labs. Antiphospholipid symptom treatment. Asymptomatic, we don't give any treatment. If we have a thrombotic episode, is heparin followed by warfarin. So DOACs do not work in this. For an INR of 2 to 3 is our goal. Chronic treatment of APS, treating the underlying disease. If APS, antiphospholipid syndrome, is secondary, anticoagulation can be lifelong for the primary disease. In pregnancy, no prior abortion, no treatment. History of pregnancy or loss, aspirin plus prophylactic heparin or low molecular weight heparin. History of prior thrombosis, you have full anticoagulation with sub-Q heparin or low molecular weight heparin. So let's do a brief discussion on enoxaparin versus heparin. Enoxaparin is low molecular weight heparin. It's a common comparison between the two. So enoxaparin is more expensive per dose, but is generally considered safer. There's less risk for hit. It's a more predictable effect. When comparing the total cost, yes, the enoxaparin will cost more, but because there's less administration, because heparin needs to be administered, if we're doing heparin needs to be sub-Q, and it needs to be administered 3 times a day. You also can have a heparin drip where you have to go through and check these measurements. It can be very labor intensive, and it can be hard to get the patient to the therapeutic dose. Enoxaparin, if you're doing a full dosing, it can be subcutaneous twice a day. The dosing is usually fairly predictable. And when it comes to the cost, because of the heparin has to have more injections a day, it's not as cost effective overall. Even though it is cheaper overall, it's cheaper than Lovenox. Continue discussion on antiphospholipid syndrome, the treatment, breakthrough clots on warfarin, add aspirin to the warfarin, switch warfarin to enoxaparin, addition of hydrochloroquine. Hospitalized with severe clotting, what's the treatment? Steroids, plasma exchange, IVIG, eculizumab. Bridging for procedures, you want to hold warfarin and transition to enoxaparin. What is eculizumab? What does it can it do? It inhibits the complement. Eculizumab inhibits complement. All right, let's get to a case with a 49-year-old male with fever, hepatosplenomegaly, and pancytopenia. This is a difficult case, and I'm including this because I'm seeing this more and more, and it's very hard to diagnose. So one of the clues is a high ferritin, 30,000. So what are we looking at? HLH, hemophagocytic lymphohemocytosis, HLH, when histocytes and lymphocytes become overactive and attack the body rather than a microorganism. So we're going to kind of talk about what's the diagnosis and then what's the potential treatment. The reason why this is so important is that if we don't get treatment right away, these patients die. They already have a high risk for morbidity and mortality, but they will die rapidly. So renal involvement in about 47% of patients. The neurological symptoms in about 31% of patients. They can have bleeding complications such as DIC, about 32% of patients. Pulmonary involvement with respiratory insufficiency, about 33% of patients. And peripheral lymphadenopathy, about 33% of the patients. Mean peak ferritin values are 30,000. When do you think about HLH? You have fever, cytopenia, that's going to be suppression of the cell lines, and organ dysfunction. It can have a high one-year mortality, greater than 50%. Just remember is that the histocytes and lymphocytes become overactive and attack the body rather than just a microorganism. It's a severe hyperinflammatory syndrome from a deregulated immune system, and you're driven by cytotoxic T lymphocytes, natural killer T cells, and macrophages with subsequent cytokine storm and end organ damage. You can have high levels of ferritin, liver and renal failure. Appearance, it looks like sepsis. It looks like sepsis that you're treating it and they do well. Triggered by infection, malignancy, or autoimmune disease. You can have the 3 Fs, fever, falling blood counts, and hyperferritinemia. This is presentation is about 62% of patients. How do you get the diagnosis? We'll get the ferritin, fibrinogen, want to get a renal panel, liver panel, electrolytes, triglycerides, LDH, and imaging. You're looking for hepatosplenomegaly. All right, so for testing for HLH is we can do an H score. And what the purpose of this H score is kind of determine what we need to do. Do we need to initiate treatment right now or to give us the probability of having it? So a cutoff of greater than 168 is considered most accurate with a very high sensitivity of 93% and an 86% specificity, okay? So we have a very high if we get a score greater than 169. So known underlying immunosuppression. Yes, that's 18 plus points, so what would that be? Considered HIV, long-term immunosuppression therapy, glucocorticoids, cyclosporin, and azathioprine. Temperature, so if we have a fever, we get 48 points. Organomegaly, if you have both splenomegaly and hepatomegaly, 38 points. If you have cytopenia in all 3 lineages, plus 38 points. Ferritin greater than 6,000, plus 50 points. Triglycerides greater than 354, add 64 points. Fibrinogen, these are all scores, things that AST, and then the bone marrow done, and the biopsy on the bone marrow. All these things are done to get the score. If the scoring system, if we're greater than 169, high probability. So what's the treatment? Treat the underlying condition if known. The aim of the initial treatment is to disrupt the cycle of hyperinflammation by inhibiting T cell proliferation and activation with myelosuppression and immunosuppression therapies. etoposide and dexamethasone can be used with and without IVIG. IVIG works by providing a concentrated dose of healthy antibodies from donor blood systems to strengthen the immune system and fight off infections or reduce inflammation in conditions like autoimmune disease. Now, what's the side effects of IVIG? Can be allergic reaction. People will report a flu-like syndrome and have flushing, nausea, vomiting, fatigue, fever, lethargy, chills, and malaise like a flu. Immunoglobulin therapies are blood products obtained from large banks. So IVIG is obtained from a large bank of blood donors. Primarily contains IgG. It may contain small amounts of IgA and IgM.